some other modalities that people are working on to try to better distinguish ischemic core and penumbra, especially on MR. But I don't think that they're going to be clinically available for a while. I think what we should really focus on is using the tools that are currently available more in a more widespread manner. So, for example, with MR, many of the centers that do MR as their acute stroke imaging are not including perfusion. And I would encourage them to do so if they can and get it done quickly. And again, with CT, I would encourage centers to add on CT perfusion. Now, another important thing to discuss, which is sort of related to your question, is what about stroke imaging at smaller centers? So in the United States, and I think in other parts of the world, what we have are networks of hospitals that participate in stroke care. So for example, in my system, we have a number of smaller community hospitals where the patients initially arrive. They're evaluated there. They have their initial imaging there. And then with the help of telemedicine, decisions are made about what treatment should be started at the outlying hospital and should the patient be transferred to the large hospital for a thrombectomy, for example. Now, a few years ago, most of these hospitals were not doing CT angio, but now in the hospitals that we cover, they're basically all doing CT angio. So when we do a telemedicine consult, we can look at the imaging and readily identify whether there's a proximal large vessel occlusion, which would then suggest that we need to transfer the patient to the large hospital for thrombectomy. So going forward, it would be good if the outlying hospitals could also add on CT perfusion, and the processing software that we have available at the large hospital hopefully could be made available to our smaller hospitals in the network, so that we could have quick identification of approximate ischemic core and penumbra. So I think what we actually need is better availability of the current tools. Now, thinking in response to your question, another exciting development that's going on right now is the availability of imaging in stroke ambulances. So there are not a huge number of places that have these mobile stroke units now, but it's increasing. The last that I heard, there were 25 or 27 stroke ambulance setups around the world, as I recall. And so those ambulances are equipped with CT. They can pick up the stroke patient, who is usually identified first by a regular ambulance, who then calls in the stroke ambulance. There's appropriate personnel on the ambulance to do a clinical evaluation, many times with the help of telemedicine, so that the stroke specialist sitting at the big hospital or at home is involved as well. They have a CT to exclude a hemorrhage and get an aspect score. Some of them are now doing CT angio, and so we can then identify large vessel occlusion. Now, what's coming is that some places are working on having MR, low field strength MR, on ambulances. So I think we're going to see that over the next couple of years, that there will be mobile stroke units that can do all three CT modalities that I've discussed. And in some places, we'll even have MR available on ambulances. So I think that's going to be a big step forward.